Coming up on the Doctor's Hospital podcast.
And studies basically show that the risk of infertility is as high as 1 in every 6 couples. A lot of patients don't realize that age also can impact fertility.
Let's face it, life is hard, but your healthcare doesn't have to be. Give yourself peace of mind with LAMP plans at Doctor's Hospital. Sign up today and enjoy the low-cost advantage. Get up to $5,000 in credit limit for non-covered services and 2 free nutritional consultations. Choose your plan today by visiting doctorshosp.com/LAMP. We make healthcare easy.
Welcome to the Doctor's Hospital podcast. I'm your host, Alexis Burrows, Marketing Director here at Doctor's Hospital. May is being celebrated as Women's Health Awareness Month, and we are excited today to be joined by one of our very own obstetricians and gynecologists, Dr. How do I pronounce this? Nneka?
Yes,
Okay.
Nneka Ijeoma.
Nneka Ijeoma. All right, so like I said, Dr. Ijeoma is one of our OBGYNs here at Doctor's Hospital, and she's joining us to talk to us about reproductive health in women, and kind of go through some of the common misconceptions, risk factors, things like that. So welcome to the podcast, Dr. Ijeoma.
Thank you.
All right, so I like to get started with kind of getting just a snippet of background on how, physicians ended up where they ended up. So what led you into the OBGYN space in the beginning?
That's a very interesting question because throughout medical school, I really thought I was going to be a cardiologist. And when I rotated through obstetrics and gynecology, I absolutely loved it. And that was it for me.
It's the beauty of the system, eh? Because in that internship space, when you go through all of the different areas of specialty, surgery, OBGYN, IM, pediatrics, the whole nine, you have a lot of people who they go in thinking one thing, and it's like you end up in that space. So that's just pretty interesting. So it's kind of like just learning to love it as you saw it and embraced it firsthand.
It was love at first sight.
Oh, that's awesome. The babies. All right. So can you provide us then with an overview, just generally speaking, of what reproductive health encompasses, and particularly in the context of women's health?
Sure. Okay. So before I actually go into reproductive health,
Sure.
health in general, just a background, when we speak of health, generally we tend to get the notion that health is well-being or the absence of disease. So it's kind of like we kind of think of black or white, but it doesn't really work like that. It's not that you don't have a disease, so you're healthy. Health tends to be thought about as more comprehensive. So when we talk about health, we're talking about a complete physical, mental, and social well-being. We tend to focus more on the physical and tend to kind of omit the other aspects that are equally as important. And not just the absence of disease. And that's actually the WHO definition of what health is. So with that in mind, when we talk about reproductive health, obviously this would be complete physical, even mental aspects of it, as well as social, in regards to the reproductive organs, their functions, and everything that encompasses all of that. So not only would this include the capability to reproduce, again, with the absence of disease, obviously the absence of disease in that aspect, it also entails the ability to have a safe, healthy sex life. And it also entails, or the right for couples to produce or reproduce when they want to reproduce, and to not reproduce when they don't.
Okay. Kind of covers the full gamut there. You mentioned mental health, and I know we have a question at the end that we're going to come around to with that. But I'm just curious, how much does stress impact women's health, and then in particular reproductive health?
So stress is a significant factor in health
Mm-hmm.
generally, and then even more so in women's health and reproductive health. And that's mainly based on factors of the society
Mm-hmm.
that you're brought up in. So there are certain norms and certain expectations that are placed on women and men
Mm-hmm.
equally. And honestly, these expectations wouldn't are generally not even the desires of
Mm-hmm.
individuals. So I have patients, I have friends who have no desire to have children,
Mm-hmm.
but it's still as if it's almost looked down upon if a woman doesn't have a child.
Mm-hmm.
So there's a lot of external forces and external norms, external stresses that's put on women,
Mm-hmm.
and stress itself can impact health and the ability to reproduce.
Right. So it's all connected in that way. All right. So what are some common misconceptions or myths surrounding women's health, reproductive health, that you encounter in your day-to-day practice?
So common misconceptions I would say the first one that I'd like to touch upon is that infertility is rare.
Mm-hmm.
Is actually not, because when you can actually and studies basically show that the risk of infertility is as high as 1 in every 6 couples.
Oh, wow.
So most times when patients come in and they complain that they have not been able to achieve pregnancy, they tend to feel isolated and think that it may just be them, it's just specific to them, not
Mm-hmm.
realizing how common this problem actually is. The second most common misconception that I personally have
Mm-hmm.
experienced is that infertility is generally attributed to the female.
Mm.
And that could be no further from the truth, because when we look at the potential causes of infertility, 30 up to 40%, yes, are female causes.
Mm-hmm.
But equally, 30 to 40% of the time, it can equally be male causes.
Mm-hmm.
And then the remaining time, sometimes you can do all the workup that you want to do, you still
Mm-hmm.
may never find a cause. So you
Yeah.
still have a small percentage that still may be unexplained.
Mm-hmm. I show my age a little bit. The song does say it takes two to make a thing go right, right? So it's equally on both sides of the fence. But I'll
Other
let you
things that
continue.
I just would like to add to that is age.
Mm-hmm.
So a lot of patients don't realize that age also can impact fertility. And this is particularly, you're seeing more career driven individuals, career driven homes.
Mm-hmm.
And what tends to happen is, as you kind of put family or starting a family on hold
Mm-hmm.
to pursue careers, when patients have already established their careers, they're kind of older in age,
Mm-hmm.
not realizing that as you age, it is more difficult
Mm-hmm.
to get pregnant.
Yeah. Because I know I think 35 is the age at which it's determined. I feel like if you have a pregnancy, it's a geriatric pregnancy. I think that's the term, right? Is it 35? Is it later?
So advanced maternal age is a kind of term that we like to use.
I'm sorry.
But yeah, the thing is, women and men differ.
Right.
Men make sperm until they die.
Right.
Now, bear in mind, age is also a factor for men as well.
Mhm.
And that is also a misconception that people
Mm.
don't appreciate.
Mhm.
So, older men, as men age, they make less sperm. They
Mhm.
make
In
the
volume.
quality of
Mhm.
it declines as well.
Mhm.
The morphology of it is not as good or
Mhm.
whatnot. To the point where they've actually done studies where they have compared men over the age of 45
Mhm.
with men 25 or under,
Mhm.
and men over the age of 45, even if they have achieved pregnancy,
Mhm.
the spouse or their partner is 2 times more likely to miscarry.
Oh wow.
And And they've attributed it to a decline in terms of the quality of the sperm.
Hmm. Right. So I guess the myth there then being um that it's okay to wait around for as long as possible before you decide to start a family, and there won't be any potential complications. Yeah.
Right. I normally tell my clients there was just one Abraham.
Hmm. That's true. One Abraham, one Sarah. Um, so you mentioned this already in discussing age, but how do other factors like genetics, lifestyle choices impact reproductive health?
So, in terms of genetic factors, and unfortunately, that is the one thing that you cannot change. So, your genes, they are the cards that you were dealt with.
Hmm.
They are the cards that you will play until you leave this place here that we call Earth.
Hmm.
There are certain genetic conditions that can predispose to infertility or even increase the risk of miscarriages. Certain conditions that one for the female, we call the condition Turner syndrome.
Hmm.
And basically, what happens is that the female is missing one of the X chromosomes.
Mm.
Um, there's other factors considered like fragile X syndrome, which we've now noted is associated with premature ovarian failure.
Mm.
Again, which obviously can lead to infertility as well. There are factors, male factors, similarly, where men may have more than one X chromosome. So as opposed to being XY,
The
they can
XXY.
be XXY, XXXY,
Oh
or
wow.
XXXY. And all of these factors have been shown to significantly affect fertility.
Okay. What about lifestyle choices?
Definitely lifestyle choices. Smoking tends to be a factor that has been proven from time. There are multiple studies that have shown that marijuana is associated with a significantly decreased sperm count
Hmm.
and sperm function. Smoking, and when I say smoking, even secondhand smoke
Hmm.
can play a significant role as well. But that too has been shown to decrease the ovarian reserve and even the quality of the follicles or the
Hmm.
eggs.
Okay. Now I know, we've had a lot of different conversations in the past few months with physicians from all over the spectrum of healthcare. And I think one of the things that continues to pop up is this idea of either early detection or um prevention. So what are some key preventative measures women can take to maintain their reproductive health throughout the different stages of their life?
So, in terms of prevention, screening.
Mm.
So, women tend to do a better job in terms of following up with their physician.
Hmm.
Not all of us do, though, but it's advised that at least yearly you
Hmm.
should follow up with your OBGYN just to get a checkup, just to get assessed. You should have a pelvic exam where they will examine to see what the uterus feels like, if
Hmm.
there are any masses in terms of ovarian masses or anything abnormal in that aspect. Generally, those exams should start around the age of about 25 or so.
Hmm.
Um, and then screening in terms of sexually transmitted diseases is actually recommended that it should be done yearly.
Hmm.
um, Women should kind of, and not women, but couples as a whole should practice safe sexual habits,
Hmm.
know your status, and know your partner's status. And if you don't know your partner's status, well, then you should know a condom or abstinence.
Hmm.
But you kind of like have to practice safe sex.
Right. You mentioned the importance of screenings, which, because I imagine that changes as women go through different phases and stages of their life. Um, Obviously, you mentioned the pelvic exam starting at 25, but what other routine or annual screenings are
So
there?
pap smears
Hmm.
definitely should be done as well. Now, the screening, and when I say we, I mean the medical community has
Hmm.
been studying cervix cancer, precancer
Hmm.
for years now. So there has been evolution of how we manage that, how we screen for that.
Mm-hmm.
And that probably will continue to evolve. But at present, the guidelines that's generally followed with that would be to commence screening at the age of 21.
Mm-hmm.
And that's more so the American guidelines. In terms of the British guidelines, they tend to recommend screening starting at the age of 25.
Okay.
So here we kind of lean towards 21.
Mm-hmm.
Now, how often you screen depends on the type of screen that you do.
Mm-hmm.
So with starting at 21, and generally I say what is recommended.
Mm-hmm.
I generally say that with hesitation because I know some of my Bahamian people.
Mm-hmm.
But generally, we've moved away from screening every year. And this applies for the
Interesting.
general population.
Mm-hmm.
So the recommendation is actually you can do if the PAPs are normal and there's no history of any abnormal PAPs,
Mm-hmm.
a pap smear actually can be done every 3 years as opposed to every year.
Okay.
Now, the reason why I often say that with caution is because when you look down the road and we're dealing with patients with cervical cancer,
Mm-hmm.
most times, almost all of the times, 9 out of 10 is the same story over and over again.
Mm-hmm.
The diagnosis is made. You ask the question, when was your last pap? The last time I had my child. How old is your child? 9.
Mm-hmm.
So a lot of women are still fearful
Mm-hmm.
of doing the pap. It is uncomfortable,
Mm-hmm.
but 2 minutes of discomfort versus a lifetime,
Right.
healthy life, enjoying watching your kids grow up,
Mm-hmm.
enjoying your grandkids, I think it's worth it.
Mm-hmm. Because we talk about the importance of early detection, and obviously that would be where the concern would come from because even if it is the 3-year time period, that's still a long enough time for something to start, grow, develop, and be well on its way, even if you do the 3 years between screening. So I mean, it's good to hear you say that these are the recommendations, but obviously, you would encourage people to, even if it's that, still do it according to that and not wait, like you said, the 6, 7, 8, 9 years. And sometimes it is for people.
Right. Now, we actually do get a little leeway. So it's the 3 years for that age group.
Bracket. Okay.
Now, once you cross 30,
Mm-hmm.
you have the option to continue doing the PAP every 3 years,
Mm-hmm.
or you have the option to do co-testing. So co-testing now would entail the cytology, which would be the PAP,
Mm-hmm.
in addition to screening for the human papillomavirus.
Mm-hmm.
Now, we are to the point where we have now recognized that cervix cancer is actually, we can now call it a sexually transmitted disease. 99% of cancers are attributed to high-risk types
Mm-hmm.
of human papillomavirus. And this is the purpose of screening with the human for the human papillomavirus.
Right.
Because if you see an abnormality with the pap and the HPV is positive,
Mm-hmm.
you want to watch these patients a lot closer.
Right.
On the flip side,
Mm-hmm.
if you do your pap and both your cytology and your HPV screening is negative, you don't need to do another pap for another 5 years. And the reason why we can extend screening from the 1 to 3 years, as I stated before,
Mm-hmm.
and even up to the 5 years, once you can confirm that there's no evidence of HPV infection, is because we know cervix cancer takes years to develop.
Understood. Okay. All right. We are having a great conversation with Dr. Nneka Ijeoma on women's reproductive health. We'll take a quick break for some word from our sponsors, and we'll be right back on the Doctors Hospital podcast.
Introducing the K. Larry Carroll Advanced Imaging Center at Doctors Hospital, your premier destination for cutting-edge imaging services. We're proud to introduce the island's only advanced 128-slice CT scanner and advanced 3T MRI, setting new standards in diagnostic accuracy at the lowest prices. Trust our comprehensive diagnostics 24/7 and easily access your results through our user-friendly patient portal. Doctors Hospital Imaging, now available at Doctors Hospital West and coming soon to Village Road. Call 302-4662 to book an appointment today.
Welcome back to the Doctors Hospital podcast. We are continuing our conversation with Dr. Nneka Ijeoma, a resident OB/GYN here at Doctors Hospital. And she is talking us through all kinds of interesting things about reproductive health in women. So we'll pick up our conversation talking about, what are some common reproductive health issues that women face, and what are some of the available treatment options for them?
Thank you for having me back again. Okay, so in my experience, one of the most common issues that patients come into the office complaining about is abnormal uterine bleeding.
Mm-hmm.
Um, Now, there are a myriad of issues that can potentially cause this. Um, Most times it may be due to underlying conditions
Mm-hmm.
like a thyroid disease, which can throw a woman's period out of balance or their hormones out of whack. Um, Fibroids
Mm-hmm.
can cause that as well, which again would be another common reason why patients would come into the office. Um, and the issue with fibroids are, depending on where those fibroids are located, how large those fibroids are, these fibroids too can affect fertility.
Mm-hmm.
Um, Being that if they are large enough and close enough to the tubes, they could potentially occlude the tubes and obviously prevent transfer or passage of both. If they are large enough and in the cavity itself, it may create a hostile environment, preventing a fertilized egg from attaching properly
Mm-hmm.
to sustain a pregnancy itself. Again, sometimes women with fibroids, even if they're able to get pregnant, sometimes they may end up with recurrent miscarriages that can be a result of the fibroids themselves. I just want to go back to the patients with that complain of abnormal uterine bleeding.
Mm-hmm.
Most times when these patients have this abnormal bleeding, which can be irregular periods, unpredictable periods, prolonged periods, um, generally these patients have what we call anovulatory cycles, meaning that they do not produce consistently
Mm-hmm.
follicles or eggs in order to get fertilized to achieve a pregnancy. And again, so the end result here again would be infertility again.
Mm-hmm.
Sexually transmitted infections is again another common reproductive problem that
Mm-hmm.
patients have. Chlamydia, one of the most common sexually transmitted diseases. Again, I just want to touch because you had asked about myths in relation to in relation to reproductive health
Mm-hmm.
before. One of the myths with sexually transmitted diseases is that they have to be symptomatic. Most times, patients are completely asymptomatic.
Mm-hmm.
Um, and that kind of, I guess, can help to kind of promote the spread. Because if you're not having any symptoms,
Mm-hmm.
you're not aware that you actually have a disease, you feel quite fine.
Mm-hmm.
And so you continue in your practices
Mm-hmm.
thinking that you're okay,
Right.
not knowing that you're spreading some kind of infection to
Right.
someone else. And then again, infertility. So some patients may have regular menses, may not have fibroids or any of these other issues that I have discussed earlier,
Mm-hmm.
but they still are unable to achieve a pregnancy. In terms of this, I would say do your research
Mm-hmm.
and know yourself.
Right.
Know yourself, know your cycle. I had a patient who came into the office, I want to say maybe about 5 to 6 weeks ago.
Mm-hmm.
The presenting complaint was infertility.
Mm-hmm.
She was trying with her husband for some time to get pregnant, was unable to achieve pregnancy.
Mm-hmm.
Did the workup, but I still, when I kind of got a history from her, how often are you having sex? Once a week, maybe twice.
Mm-hmm.
So then I told her, well, I'm not really convinced that you're infertile.
Mm-hmm.
To me, it seems like you're not trying. Now she is convinced that she is trying because she's having sex with her husband. And I'm telling her, well, unless you are going at least 3 times a week,
Mm-hmm.
and don't do it all at the beginning of the week. So generally you want to space it out a day or so in between.
Yeah.
But unless you, one, doing it every other day, and particularly during your fertile period.
Mm-hmm.
And when I said that, I saw that she looked up at me, and I made her pull out her phone.
Mm-hmm.
I encourage all patients to have a period app,
Mm-hmm.
where it tracks your period,
Mm-hmm.
because all of those apps will also tell you when your most fertile time
Right.
is. I showed her it on
Mhm.
her own phone. She
Mhm.
pulled up the app for me,
Mm-hmm.
and
So she was tracking it.
she was tracking her periods.
Right.
And I looked at the app, I looked at the fertile times, and then I told her, okay, I want you to start having sex on this particular day.
Mm-hmm.
I want you to skip a day
Mm-hmm.
and continue doing it until she was completely out of the fertile period.
Mm-hmm.
This lovely lady showed up to my office last week to
Belly
tell
coming.
me she's pregnant.
Oh boy.
And she was just shocked to say, I can't believe it, doc.
Yeah.
All of this time, and we just weren't doing it right.
Remind, because I'm familiar with this concept. It's something along the lines of like 14 days after the start of your cycle. It's something along those lines. I know it might vary depending on the like your
So
cycle and things like
generally, we
that.
use the 14-day mark,
Mm-hmm.
assuming that the cycle is 28
Regular.
days.
Right. So you have to bear in mind some people have
So
35. Right.
So it'll kind of vary. So what generally changes in terms of the length of the cycle is
Mm-hmm.
we kind of separate the cycle into like a follicular phase,
Mm-hmm.
which is the time when the egg is developing.
Mm-hmm.
And that generally tends to be, that can change.
Mm-hmm.
So it tends to be shorter in people with shorter cycles. It tends to be longer in people with longer cycles.
Right.
It's the luteal phase, or the phase after you ovulate, that tends to be pretty consistent.
Mm-hmm. Okay. Fair enough. And I have to apologize to my listeners. My wife is a doctor, so excuse me if I know a little bit too much about this stuff. But yeah, I mean, it's there's a lot there, I think, for people to unpack and kind of go through, and hopefully that helps them to understand some of these conditions that are common to, especially to our community. We talked about a little bit about stress earlier, but I want to do just, I guess, a slightly deeper dive into the concept of where mental health intersects and influences reproductive health. And then what are some strategies for women to manage their stress and, kind of be on top of their mental health in relation to managing their reproductive health concerns?
So mental health is also another important factor that can affect fertility.
Mm-hmm.
And I say that to say patients that may have like an anxiety disorder
Mm-hmm.
or stress, whether that is due to whatever may be going on currently in their life per se. Stress kind of releases a hormone called cortisol,
Mm-hmm.
and that is not really friendly when it comes to the hormones. It actually impairs some of the hormones needed to bring about pregnancy and
Mm-hmm.
fertilization and whatnot. Basically, I generally encourage patients to make a conscious effort to decrease stress levels as far as possible. I get it. Not everything is within your control, but you control how you react to your environment.
Mm-hmm.
And you need to kind of be honest with yourself and know yourself. As people and this population, we tend to be kind of afraid of help and resources for mental health.
Mm-hmm.
And just because you're seeking the care of those who are there to help us in that aspect, that doesn't necessarily mean that there's something wrong with you, or like my Bahamian people would say, you don't want to see a psychiatrist because that means that you're crazy.
Mm-hmm.
That couldn't be furthest from the truth.
Mm-hmm.
What is crazy is realizing that you have a problem that you don't want to address.
Right. And that's really the larger issue. We've kind of circled the wagon a little bit in talking about infertility and fertility challenges. What are some important considerations or steps for women who are trying to navigate, having fertility challenges or are seeking fertility treatments?
Excellent question. And I say that because you would be surprised as to how many people in this country are
Mm-hmm.
actually doing that. But The first thing, as I had alluded before, would be to know yourself.
Mm-hmm.
Know yourself, know your cycle,
Mm-hmm.
um, and then act accordingly on that. If you've tried on your own and you're trying adequately
Mm-hmm.
and you're still not getting success, seek help. Seek help.
Mm-hmm.
Find OBGYN. Some of us have special interests
Mm-hmm.
in infertility. Unfortunately, in terms of fertility services, some of them are pretty much limited in this country
Mm-hmm.
in terms of what we can offer.
Right.
But there are some treatments that can be done. Again, when you're dealing with infertility, the workup is extensive, but the purpose of the workup is to try and isolate a cause.
Right.
So if you can figure out the cause of infertility, then you could kind of tailor management and treatment around that.
Mhm.
So part of that, in terms of the female, she would be asked to do a baseline ultrasound. Again, you're looking just for anatomy. You want to make sure that the organs are present
Mm-hmm.
and they pretty much look normal.
Mm-hmm.
Aside from that, you may be asked to do what we call a HSG, a hysterosalpingogram.
Mm-hmm.
And what this is a study that allows visualization of the tubes.
Okay.
So it gives you an idea as to if the tubes are patent or open or not.
Mm-hmm.
And this is very important because the risks and the incidence of STDs are pretty high in this nation, and a lot of people do not get screened regularly.
Mm-hmm.
So if you have an STD for a prolonged period of time, it can cause damage and scarring to the tubes.
Mm-hmm. And that speaks to your earlier point about screening, about finding things out early,
Right.
early detection, screenings, that sort of thing.
And then also with that, the male, I always encourage my patients to bring your partner.
Mm-hmm.
Again, because a lot of men feel like it's not them,
Mm-hmm.
is the woman.
Mhm.
But I tell the women all the time, it makes no sense me working you up. Even if I work you up and everything seems normal, sometimes there are medications that we could give to prime the ovaries
Mhm.
in order to develop follicles and eggs. But it makes no sense me priming you.
Mm-hmm.
One, if you don't do the complete workup
Right.
and your tubes are blocked,
Mm-hmm.
because I could make as many eggs as I want.
Right.
They're never going to make it down the tube,
Mhm.
and that sperm is never going to make it up the tube
Right.
if
And
there's
so
a blockage there.
nothing's happening.
Also, I can make as many eggs as I want, and if your tubes are open, but your partner does not have sufficient sperm,
Right. Right. Because
we had a roadblock
because
again.
it takes two, right? It's not like you're having a baby. That process doesn't happen on its own by yourself. So, for us here at Doctors Hospital, obviously access is one of the critical components of our approach to healthcare. We're making a lot of efforts into making healthcare more accessible. How do societal, cultural, economic factors influence access to reproductive healthcare services, and what steps can be taken to address those disparities?
So, as I had mentioned to you before, when we speak about infertility is one of the diseases that we call a quiet disease because
Mhm.
nobody wants to speak about it. Nobody wants to speak about it because there's a stigma
Mm-hmm.
attached to it. And that in itself creates a barrier for care.
Mm-hmm.
The other issue in terms of dealing with infertility is the workup is very expensive.
Mm-hmm.
The workup is expensive. The treatment is even more so expensive.
Mhm.
So this is now an economic restraint that also adds or acts as a barrier.
Mm-hmm.
Further to that, infertility is not really covered under, and I will choose my words wisely,
Mm-hmm.
most insurance
Mhm.
plans. So insurances generally do not cover infertility.
Okay.
And by extension to that, if they're not going to cover the infertility, they're generally not going to cover a pregnancy that
Achieved
results
from
from
infertility
infertility.
treatments. Interesting.
So again, most of these patients, well, all of them generally will have to kind of pay out
Out
of
of pocket.
pocket.
Mhm.
And this is a good couple thousands of dollars.
Right. It's interesting, kind of looking at some of this conversation, there may be an opportunity there for, because I think you mentioned, having conversations about these sorts of things. So there may be an opportunity for a support group of some kind. I don't know if one exists, but given that I think we all know stories of people in our friend circle, our family circle, who have gone through the experience of having difficulties or having, lost pregnancies and things like that. And maybe there's room for something in the support group kind of space for that, and perhaps that'll help with education, with navigating through that, finding access to resources, that sort of thing.
Definitely. It definitely will help with the stress.
Right.
Because at least if you kind of at least have that support to know that you're not the only person in
Right.
this, you're not alone, you have someone that you could talk to you can relate to, because
Mhm.
they too are
Went through it.
going through what you are going through. It kind of makes the journey a little bit easier.
Yeah, it takes the stigma out of it.
Even in terms of podcasts and
Mhm.
whatnot like this, the key in terms of navigating disparities truly would be education,
Right.
getting the word out, and just educating people in terms of what it does exist among us, and how best can we kind of treat or manage the condition.
Mhm. So my last question for you, what advice do you have for women who may feel hesitant or anxious about discussing their reproductive health or their health concerns with their healthcare provider?
What I would advise is that they find someone
Mm-hmm.
that they're comfortable with. So find a physician where you can have that safe space where you can freely discuss what you want to discuss, and not really feel um, judged, or even feel like whatever it is that you're saying is silly.
Mm-hmm.
Most of us kind of understand, or we try to kind of understand what it is that you're going through. And even if some of us may not have had a personal journey
Mm-hmm.
with in terms of infertility, we still experience that journey with patients. So trust, we've been down that road
Mm-hmm.
with previous patients before.
Mm-hmm.
We've felt what they felt. We've cried with them.
Mm-hmm.
We've had the disappointments. We too feel the highs and we too feel the lows. So it's just a matter of finding someone where you feel comfortable,
Mm-hmm.
and where you can kind of create that, or they can help you create a safe space. And that way, you can open up and be open and honest, because we could only help you when you tell us what it is, what the problem is,
Mm-hmm.
and what it is that you're actually going through.
That's absolutely correct. I want to thank you so much, Dr. Ijeoma, for joining us on the podcast today. Very interesting and wide-ranging conversation. So thank you very much for taking time out of your busy schedule to sit with us and talk through this concept and this talk about reproductive health.
Thank you for having me.
And to our listeners, as always, we invite you to like, comment, subscribe, and share this with your family and friends. And we'll see you back here next week on the Doctors Hospital podcast.
Doctors Hospital Specialist Clinic is where trusted and best care meets consistency and dedication. Let our expert specialists take you on a healthcare journey where warmth, compassion, and your well-being come first. From diagnosis to prescription, we are with you every step of the way, ensuring your peace of mind. Visit us today at Centerville Medical Center, Collins Avenue and 6th Terrace, and discover quality, compassionate healthcare at Doctors Hospital Specialist Clinic.